I'm gonna walk you guys through my workflow, and then probably just give you guys like a little synopsis summary. I do like a maybe a case review. All right, so I'm gonna try to take you guys through a typical work day with me to the best that I can because I feel like I'm gonna forget something. Hi guys, it's Noreen. Thank you for making it to my channel. Hey guys, don't mind how I look, okay? I'm about to dry my hair. But really quickly, something I wanted to add that I did not say from the last video of the comparing CDI salary versus the scheduling. So when I was talking about the salary, I did mention how you could work a little bit of extra and you might be working extra, but you won't be getting paid. Like you won't be getting compensated for those extra hours you're working because you are salary. So that goes both ways. You can also be very good at your work where you're knocking it out very quickly, and once you're done with your work, you're done with your work. It's not like you have to stay and find something to do, like how they do when you're working on the floor. So if you're really good, you could really knock your work out in a few hours and then go on about your day, go on about your business. So I actually have a friend who's really, really good. She literally works 3 hours out of the day. She gets her work done in 3 hours. Like, that's crazy. And that's how she's actually able to work another job. So she actually works 2 CDI jobs. So that works for her. She's disciplined. She can do that. Me, I cannot do my work that fast. I'm just not there yet. But that's definitely something I want to highlight to you, is that if you're really good, if you're disciplined and you're focused and you like really grasp the concept, you can work a few hours out of your day, and then as long as your work is done, because with salary and with CDI you just have to have X amount of things done. Like you have to have X amount of cases done. Make sure you do everything you need to do, your recons, your new reviews, your re-reviews, all that stuff just has to be done. And once you're done, you're good. So that's definitely a pro when it comes to CDI, and something I would definitely recommend, because like I said, if you're able to do that, you can easily get you a second job, right? And then the other thing I really like about salary jobs is you don't have to clock in. At least at my facility, you don't have to clock in. You just start work when you're supposed to start work. And yeah, like my job, you can start anywhere between 6 to 9 o'clock. I go to the gym early. I just to get that out the way. So typically I start at 9 o'clock. But if I want to start earlier, like 6 o'clock, that is an option. So that is another pro. Those are other pros of CDI, and I did not mention it in that video. So yeah, and then I'll probably bring it up again if I do another CDI versus salary video. But yeah, that's definitely something I wanted to let you guys know. Hi guys, it's Noreen. Thank you for making it to my channel. I'm gonna walk you guys through my workflow, and then probably just give you guys like a little synopsis summary. I do like a maybe a case review. So first things first, I'm opening up my 3M. That's the software we use. I see I have 6 new cases. I have 10 re-reviews. That's usually because I like kind of put my patients, like if I want to review something quick, I'll probably throw it to a Friday just to double check because I usually have more time on Friday. So I have that. Then I have 7 queries that I need to answer. And out of those 7, only 2 of those have been discharged. So that means I have 5 to review. So 6 new cases, 5 answered queries to review, and then 10 re-reviews. So we'll see what I'm gonna do. So I'm pretty sure these answered queries are gonna be quick. I should really knock that out, but I already opened up a new case, so I'm gonna go ahead and knock out this new case. Um, yeah, I'm thinking like, dang, that's a lot. So what I'm gonna do is get my patient from 3M and open it over to Epic, and I'm putting it in over there, pulling up her Epic account. So while that's doing its thing, I'm looking here. So I see that the patient was in the ED, 70-year-old female, brought in by EMS. So let's see. It looks like she's having some aphasia, right-sided hemiplegia, right-side neglect, so she probably has a stroke, is what it's giving. Let's just say she has history of meningitis. All right, so I'm going to do that. I'm gonna put that what she's presenting with. Okay, let's see. Any history? Looks like she has history of smoking. So that's typically when I'm looking at the ED note, I'm looking at what brought that patient in. How did that patient present? Did they say anything about any confusion or anything like that? Or did she just have this right-sided weakness? That's the only thing she had? Okay, so then I'm gonna go to the H&P. That's where we're gonna really get down to the nitty-gritty. So, oof, they have a lot of stuff here. So she did receive TNK. So I'm definitely going to take note of that. The day that she received TNK. It's like so much stuff. So it was a cold stroke. She was last seen normal prior the day before. CT shows no acute intracranial abnormalities. Same for the CTA. So I'm gonna go ahead and start putting that into my diagnostics for the CT and the CTA so that I don't have to worry about that later. And then we're gonna go about 2-3. And we're gonna go down. So she got TNK. So I'm gonna also code that TNK. So she's being worked up for acute stroke, history of smoking. Okay, so my PDX, that's the principal diagnosis. I'm gonna make that stroke for now until they like rule it out. She did have some aphasia, we saw that. She has some eye deviation, right visual, some homonymous. Okay, and she does have history of a stroke. Interesting. So, inappropriate words. Nothing telling me she's confused for me to ask for encephalopathy, because that's usually the first thing that I'm trying to go for. Some history of hypertension, dysphagia. All right, so while I'm saying it, I'm coding it. Like there's a way you can click on it and it'll go to the code. You just have to make sure the code is accurate. So then in my notes, because what I'm doing in the template with you have to put all your information in it, you have to add your finding. And you add that into your the 3M account, and that is how you get credit for your case review for that day. Add finding. And you have to make sure you put pertinent information, like anything you would use to help anything you would use to basically like query. So dysphagia, they say dysphagia for everybody that comes in for a stroke. Hyponatremia. They say hyponatremia. I want to make sure this is real. So, yep, she has some hyponatremia. I see that. So I'm going to go ahead and add that to my labs. But it's been resolved. So that's good. So since I'm already here, let's just look at the labs. Some hyponatremia. Chloride was elevated today. Creat is good. Like that's like one of the main things you want to check creat, because if there's AKI and you don't capture it or don't rule it out, then you're losing points. But creat is good, no issues there. Kind of going all over the place right now. This is not my usual flow, but sometimes you gotta switch it up because yeah. She got some hypoalbumin, some hypocalcemia. Dang. Her cal was 6.9. Hyperphos. What's going on here? Okay. Elevated lipase. We saw that. Low CK. No heart stuff going on over there. Checking the WBCs. Hemoglobin came in at 9.7. Hematocrit 29.9. Platelets on the upside for 26. So I am putting all of this in there like so. Let's go down here. They did some INR, PTT. Okay, they did a UA, nothing going on over there, so I'm gonna leave that alone. So typically, actually, when I go into Epic, I start off with the BMI 21, so that's good because obesity is a big deal, and so is malnutrition. Those are the ones you really want to capture. Um, then I go to check the skin. Skin's intact, no issues there. Then I go to the home meds to see what are the home meds, so I know if anything is new. Budesonide, so she must got some breathing stuff going on because she takes that from home. Um, let's see. Then I go to the vitals. All right, everything looks good. Everything looks like it's within defining limits. So I'm just writing that down so that I have it in my notes. Then I'm looking for any DSATs. I'm looking for any high blood pressure. Everything looks good within normal range. She's on room air. BP is stable. It's looking good so far. Ooh, BP dropped a little bit. 88 over 45. What's going on over here? And so today vitals are all normal. Love to see it. The sticky note is bothering me. All right, now I'm in the med section. I'm looking at what she got. So I see she's getting boost. Off rip. Oh, off rip. I don't know if I should say that. Immediately when you see that the patient's on boost, you know that's an option for malnutrition. She's also getting some multivitamin, pseudoephedrine, some flushes, thiamine. Yeah, what's going on here? Sometimes it could be alcoholic too. They can be an alcoholic. I see she got some boluses. She got 2 boluses, a liter bolus on 2 days. So I'm also going to take note of that, of the date as well. She got 2 boluses, a liter, and then she got a 500. T and K. Oh yeah, we got the T and K already. All right, and then we already did the lab. So that's what I do in Epic. So then we're back over here. I did see that she had hyponatremia. Then she did have some anemia on admit. Then they're saying coagulation, unspecified medication induced coagulopathy. So that's gonna be D6832. So once you like do this enough, you know which code to use because sometimes the automated codes are not accurate. Like this coagulopathy D689, it's unspecified, but they send medication induced coagulopathy, so you know kind of which one you need to use. Like I'm used to it, so I know it's gonna be D6832. So I can go ahead and put that code in. So you can put the code in manually if you know it, but if not, this thing will it'll automate it for you. So that's the whole H&P. So now I'm looking at, I don't even know who this is. I'm guessing this is neuro who came to see the patient. What is this? Okay. Neuro, seeing the patient. They're saying about her history. Yes, personal history of this. History of migraines, former smoker, yada, 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 blah, blah, blah. Tell me something. Oh, so yeah, so this is teleneuro. So they ain't saying nothing. I mean, what type of acute onset inability to speak in right hemiparesis, expressive aphasia? We already knew that. Okay, so they basically said the same thing. Acute left MCA ischemic stroke. We got the hemiplegia. Did I not get that earlier? I guess not. So whatever. So I am gonna put this doctor. I'm gonna list them as a consult 2-3 neuro, and he said the same thing. The acute MCA stroke. So I'll put that in my note. Oh, let me put left MCA stroke. It's more specific. All right, so that's that. That's the only thing I see reasonable there. It's a high suspicion of occult AFib. I don't know what that means. Does the patient have AFib or not? Oh, I got this. Why does it not keep going? Hemiplegia. All right, so we have the A. So I'll follow up to see what's up with this AFib situation. Then let's go to the next one. So card is on the case. Card was another consult, so maybe this AFib is real. They're gonna give us the answer we're looking for. She has no prior history of cardiac issues, including AFib or aflutter. There has been no incident of AFib. Okay, so I have explained to her this likely the cause, but we have not really ruled out the possibility of AFib in this patient, and this is why a heart monitor is suggested. So they don't really know what's going on either. It seems like. So the diagnosis that I got. So basically, when you're going through this, you're trying to get the diagnosis. So card. The only diagnosis they said is aortic atherosclerosis and hypotension. So that's what we're gonna do. They didn't list that AFib, so I'm not gonna code that AFib because they seem to be very finicky and iffy on this AFib situation. So we did see the hypotension. And so also too, when you're doing your codes, you have to put whether it was present on arrival or not. That's like a really big deal. If your POA status is not accurate, that's gonna be a problem. So then I'm gonna go. So that was it for the consults. Now I'm going into the progress note. I'm looking at what ICU said on this day 2-4. So I'm gonna put that in my Word document. My template's in a Word document. I type everything up there and then I copy and paste it into my 3M at findings. So patient had an episode of nosebleed, applying pressure, coags, suspect lab error. Okay, so just a nosebleed, nothing crazy going on. Let's see if anything else. So I'm gonna code some of the meds. Sometimes it asks if like patients on aspirin, things like that, or any steroids, which we know she is. Okay, so I'm gonna come down a little bit more. So it doesn't look like any new diagnosis here. Speech put here. I don't know why speech is here, but speech in this is the wrong section. So no dysphagia per speech, so that's good to know. But I'm gonna list this in the consult area. Then the next note, ICU next day, neuro exam greatly improved without aphasia. Okay, love to see it. I guess I'll code that epistaxis too. Stop Plavix and start Eliquis. Let's see. I'm tired. I'm not even gonna lie to you guys. It's Sinus Brady. She didn't come up with that Sinus Brady, did she? I'm ready to go to bed. So they're trying to figure out. They still new stroke, possibly due to aortic arch or undiagnosed AFib. So they still don't know the story with this AFib. So I'm also gonna make a note, follow up with this AFib, follow up with this AFib. Oh, I'm also gonna make a note on possible query opportunities. So like that malnutrition, we saw that. So I put a note to follow up on this AFib. I'm gonna give them a few days to figure it out. Then for the next day, mitogen for the hypotension. That's all they said. Sounds good to me. So that hypotension, we know that's a diagnosis. I'm gonna go down, no other diagnosis. All right, so that's actually all my notes for that case. This is like very rare. They're usually long, okay? Then I see OT saw the patient, said the patient has some generalized weakness, standing balance. They recommend OT, so I'm gonna put that in my note. Then PT saw the patient as well. So they said unsteady gait, risk of falls. So we're gonna put that in there as well. Chaplain seen the patient. RD seen the patient. So RD said inadequate oral intake. That meets the criteria for my facility for me to be able to query for malnutrition. So there we go. We made that note. Remember I said when they're on Boost, when they're on like Boost, Premier, you know, those kind of things, any type of supplement, you can query for mild malnutrition per my facility. Every facility is different. So as I'm adding that to my chart, what RD said, I'm gonna start working on my query. I'm gonna list that as a sign and symptom. I'm gonna get the risk factors, basically what the patient came in with, and just basically start building my query as I go along. And so the patient's on Boost. We saw they were getting some thiamine, multivitamin. They're on adult diet regular. And then we're just gonna monitor for weight changes, nutritional labs. Her albumin was also low. I could put that in my query as well, but I have enough. I don't need to do all that. It will just make it better. So boom, I got one query down. PT tell the patient again. Blood pressure low. We saw that. Now I'm gonna go into the diagnostics, EKG, sinus Brady. Oh, so she was Brady on admit, or was she not? So it's saying sinus Brady. So let's see. EKG, sinus Brady. All right, TTE, EF, 55, 60%. So I'm putting all that into my notes. CT brain. Remember, I already started collecting this, so no acute abnormality. Chest X-ray, no acute abnormality. But I'm just gonna list that they did one in my notes, so I don't get points deducted. No LVO. We saw the CTA. They did a repeat CT. It looks like nothing there. And then they did an MRI. So if they're saying, so then this is when it gets tricky. They keep saying stroke, 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 but the imaging is not showing any stroke. So what is it? So I'm gonna make a note to follow up on that, because the MRI is saying faint puncture area restricted diffusion, blah blah blah, may represent subacute infarct. Okay, so they're still trying to figure things out. Multiple scattered punctuates. Okay. Yeah, so we're just gonna put a note on that because it's looking real finicky right now. Torvastatin. Okay, and that was basically the chart review. Right now my SOY ROM is a 3.2. The goal is a 4.4. That's like the highest, and your patient is getting like the most. My DRG is 0.62, correct. Again, I have that stroke right now as the DRG, but we're still trying to figure it out. Then there's a way you can go through your codes, the automated codes, to make sure you haven't missed anything. But like I said, like it'll give you stuff that's not even accurate. Like how they said that she has no demonstrated AFib and no diagnosis of it. The code is pulling up AFib because they see that word AFib. So you still have to go through it to see if it's accurate or not. So that's not accurate. So I'm gonna ignore that. They said she has some history of emphysema in there. I wouldn't be surprised because she has history of smoking. So I'm just gonna kind of read through to see if I can catch this emphysema, which I really don't see it. Okay, she does have history of emphysema, so I'm just go ahead and code that. We know she came in with the facial weakness, no neglect syndrome. She has history of like a TIA. So we're gonna see there, and so also to just want to go through everything, make sure everything's correct. Oh wait, they said right side neuro neglect syndrome, so I'll go with that. So everything looks good. Also, when I'm also looking at the labs, I'd like to see what I could possibly query from the labs, because those are like easy query opportunities. But they already said hyponatremia, hyperchloremia. That's not that important. I think I saw some. So we have hypoalbumin, hypocal. So I'm just gonna take note of that. Hypoalbumin, hypocal. She had hyperphos, but it was only one time. So this hypocal though, she was at 6.9, but I don't even know, did they even give her anything for it? Because most of the time when you want to query for something, you want to make sure the patient was treated for it. You don't just want to, yeah. Like it has to have an intervention, like something has to have been done for you to like for it to really be query worthy. Um and it doesn't seem like they did anything for that, so I think I'll just leave that alone. So let me just go back to the MAR and double check. And then you can like search to. My legs hurt. So yeah, it doesn't look like. Hold on, there's no way her calcium was that low. They did nothing. Oh, looks like it. Okay, so there's that. So that is that. So now I'm gonna copy and paste my Word document into my ad finding, and then the notes that I made, like follow up with the AFib, hypocal. I also need to put follow up with stroke too. Oh, I need to complete my codes, because if you add your codes, you don't complete it, it won't save, you won't get credit. So you have to always remember to complete your codes, which is very easy to forget. And then you're gonna do a follow up. You're gonna schedule a follow up, and in your follow up, you can put notes and stuff. So I'm gonna put that like follow up with the AFib situation, follow up with the stroke. I'm sending my malnutrition query, so I can go ahead and remove that part. And then I am going to, so when you do your follow up, you say like, what are you following up? It's going to be, I have a pending query response because I'm sending a query. I'm going to set the follow up day to Monday because today is Friday. And so I do that in 3M. Then I'm going to copy and put my query in 3M. My nutritional query. And so when you're sending a query, you have to make sure you use the right template. So since I'm trying to get malnutrition, I'm going to use a nutritional status query. But for example, if they said malnutrition and the patient didn't have malnutrition and I wanted to rule that out, I would use a malnutrition clinical validation query template. And it gets like really complex. Like you have to make sure, like if you're trying to capture like anemia, nobody said anemia, you would use hematology. But if somebody said anemia in the chart, but you want to specify the anemia, you would use the anemia query template. And then there's just like so many of them, like respiratory failures, infectious disease, like all sorts of stuff. So yeah, and so I need to see who I'm gonna send this query to. This patient is in the ICU, so I'll look at the last doctor to do a note. The last like 2 doctors, because some of them are day shift, some are night shift. So I know that I'm sending it to the right doctor, and I can get a response pretty soon. And so yeah, I'm gonna send it to this ICU doctor. But my doctors are usually pretty good. They're very responsive, like a little too responsive. I'm like, dang, like I just sent you that query. Breathe. So yeah, and then when I first started off, I'm not even gonna lie, I used to send it to the wrong doctor because some of the doctors have the same last name. So yeah, gotta be careful. Make sure you're sending it to the right patient, to the right doctor. They'll be like, that's not my patient. So yeah, I found the doctor. I'm going to send it to the doctor in Epic, and then that's it. That is my case review. So that is yeah, that's that. So that's 1 down and like what, 20 more to go. Jesus. But yeah. So I'm gonna do, I haven't really figured out my workflow yet, but I don't know. Like I'll start with my new cases, but I feel like the new cases are so draining that sometimes I feel like it's better when I start off answering my queries and doing my re-reviews and then doing my new cases. But I don't know, I just be all over the place. I don't really have a system. Like it is what it is. Well, for now, for today, I'm gonna continue to do my new cases until I kind of get tired of it. Then I'll switch over to my answered queries. So I have to do that, and then I also have my recons. Recons are like basically after the patient's discharge, you have to go through your codes, make sure they match coding's code. And I'm like really behind on my recons for last month of January. So I need to like also put in time into that to get that done. Which I don't really like doing recons, if you haven't noticed. We're supposed to do a little bit every day, and I don't. So that's why it's like kind of piled up now. But I'm gonna try to take care of that today. I always say I'm gonna work on it on the weekends, but that usually never happens. So I'm gonna try to do that now because since the month is over, it kind of needs to be taken care of. And then yeah, I'm actually hungry, so I'm gonna go get some breakfast. So yeah. I'm not sure what this video is gonna be. It was supposed to be CDI workflow, but it kind of turned into a chart review. So I don't know if I'm gonna put it together or separate it. But yes, I hope you enjoyed this video. I hope you found it helpful. If you have any questions, just let me know. And yes, thank you.